Welcome to pulmonary function measurements. Lung volumes and capacities. First, we're going to talk about lung volumes. The four lung volumes are tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Tidal volume is the first that we'll talk about, and tidal volume is simply the amount of air inhaled and exhaled with each breath during quiet breathing. It's about 500 milliliters in a normal adult male or female. The second lung volume that we'll talk about is the inspiratory reserve volume. That is the amount of air that can be forcefully inhaled beyond the tidal volume. It's about 3,100 milliliters in an adult male and about 1,900 milliliters in an adult female. Expiratory reserve volume is the amount of air that can be forcefully exhaled after a normal tidal volume. It's about 1,200 milliliters in an adult male and about 800 milliliters in an adult female. Residual volume is the amount of air still in the lungs after a forced ERV. It's about 1,200 milliliters in an adult male and about 1,000 milliliters in an adult female. Residual volume is what's left over in your lungs and doesn't go away. Lung capacities are made up of two or more lung volumes. The first one we'll talk about is the vital capacity. The vital capacity is the maximum volume of air that can be exhaled after a maximal inspiration. It includes the tidal volume, the inspiratory reserve volume, and the expiratory reserve volume. It's about 4,800 milliliters in an adult male and about 3,200 milliliters in an adult female. The inspiratory capacity, or IC, is the volume of air that can be inhaled after a normal exhalation. The inspiratory capacity is equal to the tidal volume added to the inspiratory reserve volume. The next capacity that we'll talk about is the amount of air remaining in the lungs after a normal exhalation. That's the functional residual capacity. The functional residual capacity is made up of the ERV and the RV together. Total lung capacity is all of your volumes added together. It is the maximum amount of air that the lungs can accommodate. Total lung capacity is equal to tidal volume plus inspiratory reserve volume plus expiratory reserve volume and the RV. In a normal person, this is a normal male, this is about 6,000 milliliters. In a normal female adult, it's about 4,200 milliliters. Approximate lung volumes. So, does anybody remember how much an approximate tidal volume is for a normal adult? It's about 500 milliliters. Good for you if you were able to answer that question. And how much is a normal inspiratory reserve volume for a normal male? If you said 3,100 milliliters, you're right on. What about about expiratory reserve volume? What is a normal expiratory reserve volume for an adult male? If you said 1200 milliliters, then you are correct. And the residual volume, what's left over in the lungs? What is that for an average adult male? It's about 1200 milliliters. Great job. But what about the capacities? What is the normal vital capacity of an adult male? If you said 4,800 cc's or milliliters, you're absolutely correct. And what about inspiratory capacity? What's a normal inspiratory capacity? Do you remember? If you said 3,600 milliliters, you're absolutely correct. And functional residual capacity, the ERV plus the RV. What is a normal functional residual capacity? If you said 2,400 milliliters, you're absolutely correct. If you said 6,000 milliliters, you are absolutely correct. Let's look at what these look like. Here, you can see the total lung capacity, which is all the volumes added together, IRV, tidal volume, ERV, and RV. Inspiratory capacity, noted here, is made up of the IRV, tidal volume. Functional residual capacity, or FRC, is made up of the ERV and the RV. And vital capacity is made up of the IRV, the tidal volume, and the ERV. Pulmonary mechanics. Pulmonary mechanics, in addition to measuring volumes and capacities, also measure the rate at which gas flows in and out of the lungs. Expiratory flow rate measurements provide data on how well the airways are working and the severity of airway disease, as well as indicating if the patient has a large or small airway problem. Collectively, the tests for measuring expiratory flow rates are referred to as the pulmonary mechanic measurements. The tests for measuring expiratory flow rates and lung volumes and capacities are referred to as pulmonary mechanics. These measurements give the RCP, or respiratory care practitioner, insight into how well the lungs are working and if the airways are damaged, and what kind of damage. Let's talk about forced vital capacity first. An FVC is the maximum volume of gas that can be exhaled as forcefully and as rapidly as possible after a maximal breath in. FVC is one of the most commonly performed pulmonary function measurements, and in a normal individual, the amount of time required to complete an FVC is about 4 to 6 seconds. However, in obstructive lung disease, it often takes much longer to exhale. A forced expiratory volume is in 1 second, or FEV1, is the maximum of volume of gas that can be exhaled in 1 second. Patients with obstructive pulmonary disease have a decreased FEV1. Patients with restrictive disorders may have a normal or may also have a diminished FEV1. Using the FEV1-FVC ratio, or FEV1%, and FEV helps to categorize a patient's COPD for the gold standards as Stage 1, mild, Stage 2, moderate, or Stage 3, severe, or Stage 4, very severe. Based on the patient's COPD stage category, an appropriate treatment program can easily be developed. I want to look at some of the common flow volume loops with you. Depending on how well your equipment works, several important measurements can be obtained from a flow volume loop, including a peak expiratory flow rate, a peak inspiratory flow rate, a forced vital capacity, an FEV1 to FVC ratio, and forced expiratory flow, 25%, 50%, and 75%. Flow volume loop measurements graphically illustrate both obstructive and restrictive disease problems. Normal, early obstructive disease, chronic obstructive disease, a fixed airway obstruction, a variable exothoracic large airway obstruction, and restrictive disease. Factors that affect predicted normal values include height, weight, age, gender, and ethnicity. Among individuals of the same gender, height is the most important factor that affects pulmonary function. Taller subjects have greater pulmonary function values, especially in terms of lung volumes and lung capacities. An individual's height is not as significant in expiratory flow rate measurements, such as FEV1 or peak expiratory flow rate. And in children, normal pulmonary values are more directly related to height than age, right up until a child is about 60 inches tall. After a child reaches this height, the age of the patient begins to be a factor in predicting normal values. A patient's weight is sometimes taken into account along with height. The effect of weight on a patient's lung volumes can be seen when comparing adult subjects of the same height, especially in patients that are morbidly obese. In general, as weight increases beyond a patient's normal BMI, lung volumes will decrease because the amount of weight on the chest. The age of a patient can also affect normal lung and volumes and capacities. After the age of 25, lung volumes, expiratory flow rates, and diffusing capacity values all tend to decrease. The gender of a patient affects the predicted normal pulmonary function values as well. Male subjects typically generate greater predicted lung volumes, expiratory flow rates, and diffusing capacities than female subjects of the same age and height. The last factor that affects predicted normal values of pulmonary function tests are ethnicity. Black, Hispanic, and Asian patients typically have a smaller predicted pulmonary function value than subjects of European descent. This is the end of our presentation on basic pulmonary function values. Thank you for your time and attention today.